Good afternoon. We're going to start again. If Dr. Reeves would take his seat. He's busy drawing over there, but he'll join us in just a moment. So we have several sessions this afternoon, but we're going to start off looking at team-based outcomes, teams being one of the key elements on the pathway between IPE and enhanced clinical and population and system outcomes. So we're delighted to have Shirley Sonesh with us. Eduardo Salas is actually having fun in Italy and will not be with us, but we're still delighted to have Shirley with us. And Shirley and Eduardo hail from the University of Central Florida. So take it off.
Great. Good afternoon, everyone, and thank you for coming right after lunch. I appreciate it. My name is Shirley Sonesh, and I'm a research scientist at the Institute for Simulation and Training. That's at the University of Central Florida. And I work there with Dr. Eduardo Salas, who many of you may know as the teams guru. He is very prolific in researching teams and team training in high-stakes industries, including healthcare. And so today, I'll be talking to you guys about team training and patient outcomes. I'll start off with talking about why interprofessional education is critical to examine in today's healthcare arena. I'll then talk about what is team training, how do we define it, and how should we, in the future, propel these team training initiatives. I'll talk a little bit about what we know about team training effectiveness, and then I'll describe the results of our research over at UCF. We conducted a comprehensive meta-analysis on all the studies that have attempted to quantify the impact of medical team training. Then I'll discuss, and hopefully this will spark some discussion, some of the limitations or the gaps of our research, and hopefully that'll spark some ideas for future directions and insight into what we can do to really strengthen and make more robust the science of team training. And of course, I'll leave some time for questions and comments. So undoubtedly, interprofessional collaboration in today's healthcare arena is critical. It's seen as essential. Many collaborative care models have been developed and applied. And as we know from today's talks, there's a great deal of heterogeneity in those collaborative team models and the competencies that we care about. But we do know that overall, collaborative care does improve patient safety and satisfaction. It improves the ability of clinicians to be able to provide better quality and patient-centered care. By engaging in collaborative care, you have a newfound respect for other professions, and that helps to create a more manageable workload because you're more likely to help and provide mutual support to your team members. And it supports the exchange of ideas, skills, and knowledge. And studies have even shown that it does reduce patient morbidity and mortality, and I'll talk a little bit about that in my research. So I think it's important to discern what team training is. So many organizations have begun to adopt team training initiatives, but oftentimes it's lacking. And so I think it's very important to describe what it is and what it is not, so that when we do make the effort to engage in team training, it's based on known and true features of training that work. So it's a family of learning strategies that helps to impart the systematic acquisition of teamwork KSAs, or knowledge, skills, and attitudes. And it focuses on imparting the cognitive, behavioral, and affective team-based change. So what that means is we care about how team members think, what team members do, and how team members feel. So just to provide some examples and context, when I say how team members think, it's not how they think, but do team members share the same understanding of the goal, the same understanding of the task. In this case, it should ultimately be the patient is the ultimate goal, providing the best patient care possible. In terms of behaviors, team-based behaviors include good leadership behaviors, communication protocols, mutual support behaviors, among many, many more. And in terms of effective team-based change, we're talking about how team members feel as being part of a team member, as part of a team. Do they have that collective efficacy? Is there psychological safety? Do they feel safe taking interpersonal risks on a team? So we look at all these different outcomes. Team training needs to be a planned activity. It can't be a side thought. It needs to be based on pedagogical principles. So first, you need to come up with very specific learning objectives, and once that's determined, you can start building a team training that's based on those learning objectives, and where you define the specific knowledge, skills, and attitudes that you want to impart. What team training is not, though so many organizations rely on this, is a group of people in front of a mannequin. It's very easy to say, we're going to do this simulation, put a bunch of different professionals around a mannequin and say, go. But that's not enough. They need to know the basic principles that they're supposed to enact as a team member to fully enact teamwork. Team training is not a place, it's not a program, and it's not a workbook. As I said, it needs to be based on pedagogical principles, it needs to be planned, and it needs to be, there needs to be some level of didactic training before you go into simulation training. And it's not just saying do better. So many organizations say we reinforce teamwork, we really value teamwork. They don't provide the specific tools for clinicians to be able to really be good team members. So before I go on to describe our research, I also wanted to define how we conceptualize interprofessional teamwork. Often in the literature, interprofessional teams and interdisciplinary teams are used interchangeably, but we really wanted to look at them separately. So interprofessional teams we're conceptualizing as a group of professionals that includes nurses, physicians, radiology techs, and so on. Interdisciplinary teams, on the other hand, look at the departments of the clinicians and the disciplines. So it could be a cardiology physician working with an emergency medicine physician with an obstetrics physician. And of course, an interdisciplinary team might also be an interprofessional team, so they're not mutually exclusive. But we wanted to distinguish so that when we ran our analyses, we could see if medical team training behaves differently for either of these two groups. Is it more difficult to impart teamwork competencies when you're an interdisciplinary team? So before I go too far, does team training in healthcare work? Well, I'll talk about what we do know. We know that there's a wide spectrum of programs and vendors of team training. The most widely accepted and known in healthcare is TeamSTEPPS, which was a DoD initiative, and that's widely adopted, maybe not widely enough, but in some organizations. Some other training programs include crew resource management and crisis resource management, and these were based on aviation training and adapted for healthcare. In 2008, Salas et al. Conducted a meta-analysis to see if team training works across a variety of industries. So they looked at, in addition to healthcare, they looked at military and NASA and aviation and other high-stakes industries. And they did find that team training was effective in imparting team-based skills, team-based attitudes, and team-based cognition. So it's effective for a variety of industries, but how do we know that it's effective for healthcare? Well, there are a lot of qualitative reviews of literature that point to, yes, team training is effective. But where is the empirical evidence? So we sought to answer that question and fill that gap by conducting a meta-analysis on team training in healthcare. And for those of you who don't know, a meta-analysis is just an advanced statistical procedure that's used to determine a more true effect. We gather all of the research studies examining a relationship of interest. In this case, we collected all the studies that looked at team training in a healthcare context. And then we aggregated all the statistical data across the studies to find one common metric. And meta-analysis corrects for unreliability and it corrects for sample size, so we can place some more confidence in the overall effect. So I'll just quickly give you a brief of our methodology, but we searched several databases, including medical, business, and psychology databases using team training search terms, team leadership, team communication, and others. To be included in the meta-analysis, the study needed to have trained team-based skills in a healthcare settings with a healthcare population. It needed to be empirical, and it needed to provide the effect size that we could convert to a common metric. In this case, we used Cohen's d. And once collected, we coded the studies, and we followed all PRISMA guidelines, which is just a preferred reporting system for qualitative and quantitative reviews. So how do we determine training effectiveness? And this was a question we heard a lot this morning. What is effectiveness? What is the criteria that we should use to determine whether team training works and interprofessional education, whether that works? Well, we based our evaluation on Kirkpatrick's framework for training evaluation. And there's 5 levels. Level 1 is just the reaction data. Did the participants like the training? Did they perceive it as useful and interesting? Level 2 is about learning. What skills, knowledge, and attitudes changed after the training? Did they acquire any new team competencies? Level 3 looks at behavior or training transfer. And somebody mentioned this morning, okay, they learned. That's a very proximal outcome. But can these trained competencies be applied to the job where the situations and contexts are much more stressful? There's patient acuity. That is the real question. That's where the patient is going to be most affected. So we looked at that. Did the participants change the behavior on the job based on what they learned? Level 4 looks at organizational results. Did the change in behavior positively affect the organization? And so we looked at outcomes like the culture of safety, the culture of teamwork, cost outcomes, reduced readmission rates, outcomes like these. And lastly, typically Kirkpatrick's level 5 looks at return on investment. And while this is an important question, very few articles actually report that data. So we actually, because of the question we're asking, looked at patient outcome data. We looked at patient satisfaction, but also patient safety outcomes. We looked at reduction in complications, morbidity, mortality, and other patient issues. So as a result of our search, we identified 87 studies that were ultimately included in the meta-analysis. Of these, there were 100 independent samples that we could meta-analyze. And just to give you a background of the type of samples that were included in the majority of these studies, 76% were non-military clinicians, practicing clinicians, while 18% were student samples pre-licensure. The most frequently used team training program was crew resource management at 22%. And most of the teams that were trained were interprofessional, 74%, but there were only 28% interdisciplinary teams, which makes sense simply because departments don't often train together. Communication was the competency most commonly trained, and this is to be expected because communication breakdowns are one of the most highly listed challenges and problems in healthcare today. So what did we find? Let me just walk you through this table first. K represents the number of independent samples that were included in the analysis. N represents the sample size of all the aggregated studies for that particular outcome. The corrected DRM is the corrected Cohen's d effect size, which essentially tells you how much of a standard deviation increase happened as a result of the team training. And lastly, the variance accounted for simply tells us how much of a change in that outcome can be attributed to medical team training. So I'll walk you through some of the results right now. Overall outcomes, this is just an aggregation of all the 5 levels, Kirkpatrick levels together. So team training improved overall outcomes by 9.5%. For reactions, we did find that team training was well liked and perceived as useful, 9.5%. And while I believe one of the committee members said, you know, too many studies look at this, we don't really care what they think of team training. But I do think it's important if you consider the unconscious bias and the tribalism that exists between professions. So even attitudinal data can help to uncover why IPE might be challenging, and team training might help to reduce those attitudinal barriers. We also found that the largest increase due to training was in learning outcomes. This is to be expected because learning is the most proximal outcome of team training. That is the #1 goal. It improved learning and the acquisition of skills, attitudes, and knowledge by 21.2%. a little over 10% improvement on on-the-job performance. And this includes both task and team performance. So yes, they enacted better communication and better leadership and better situation monitoring, but that also translated into providing more accurate procedures and other clinical skills that I might not be as familiar with. In terms of level 4, team training accounted for a little more than 3% of improvement in organizational outcomes. And again, this included things like culture, reduced turnover, very few but some financial outcomes improved. And finally, and I think that this is the most impressive, team training accounted for a little under 5% improvement in patient outcomes. And so there were about 3 studies that looked at mortality. And so while this is quite small, it still shows a reduction in mortality, which is quite huge in my opinion. But we also saw a reduction in infection and complications and an increase in patient satisfaction. We also went ahead to look at whether team training behaves differently for interprofessional teams and interdisciplinary teams as opposed to other teams. And again, 74% of the teams that were included in this analysis were interprofessional, while only 28% were interdisciplinary. What we found is that overall, looking at all the outcomes together, medical team training was as effective as interprofessional and interdisciplinary teams for interprofessional and interdisciplinary teams as it is for homogenous teams. So there's no drawback in combining different professions for team training. On the other hand, when we looked at each outcome more specifically, we took a deeper dive, we found that non-interdisciplinary teams and non-interprofessional teams, so homogenous teams, they did perform better in terms of learning outcomes and transfer of training outcomes. And this might be due to logistical issues of training interprofessional teams. It might be due to the challenges of contextualizing the training and the jargon and the communication barriers. On the other hand, there was no difference for reactional data, organizational results, outcomes, and for patient outcomes. So essentially, what this finding tells us is that this warrants a deeper dive into the features of team training that work for homogeneous teams but might be a little bit more difficult to translate for interprofessional teams. So we really need to take a closer look. We also wanted to see, does team training work better or worse for some type of trainees versus others? So team training was effective for all types of trainees, but practicing non-military clinicians benefited the most overall across all the outcomes. Students, though, experienced the greatest increase in learning as opposed to non-military clinicians and military clinicians. And to explain this finding, it might make sense simply because students are a little bit more open to working with others. They might not have those preconceived notions and biases towards other professions that might happen due to the culture or the institutionalization of the hierarchy between professions on the job. Military clinicians benefited slightly less overall, but there were only 3 studies that looked at that trained military clinicians, and so this result should be interpreted with some caution. We looked at other components of team training to see what works and what doesn't work. So we looked at duration of training. Does it matter how long or how short training is? We did find that the longer the training sessions, the more improvement in learning there was. There were no significant effects for any of the other outcomes, though. Opportunities for practice during the training also was shown to predict team training effectiveness. It improved learning and improved behavioral transfer. And this just goes to show that while didactic training is crucial, we also need to provide ample opportunities to practice those competencies. We also looked at training strategy. So again, you've got didactic training, lecture-based, demonstration-based learning where you provide videos or examples of effective versus ineffective teamwork. And the most engaging is practice using simulation, whether it be high fidelity or low fidelity mannequins. And so we wanted to see what works and what doesn't work in terms of strategy. We found that simulation enhanced training learning outcomes. But we also found that using a combined training strategy with simulated practice and information and demonstration is going to be more effective than simulation alone for the 3 outcomes of learning, behavioral transfer to the job, and organizational outcomes. And again, this is going to be expected. You're providing a combination of modalities for training. It's going to be more engaging, providing opportunities for practice, but preceding that with the specific competencies and making sure you're imparting those skills before they have the opportunity to practice. So we did find that the more engaging the training was, the more effective it's going to be for the outcomes that matter. So what do these results all mean? Well, we found that team training works for interprofessional teams, but it comes with some challenges. It's going to be more difficult than training homogenous teams. It requires a closer examination, and we need to enhance the methodologies for interprofessional and interdisciplinary team training. We really need to look at how we're designing and implementing team training for interprofessional teams. And I think it's important to note that not all teams are created equal. There's going to be a variance in the sense of how interdependent each team is going to be. And that also depends on, what department you're working in, how acute care you're providing. We also need to improve the organizational conditions for on-the-job use of teamwork and interprofessional teams. It's not just the team training that helps on the job transfer, but it's all the organizational conditions, the support from the leadership, the cues that they give, the posters on the wall, everything that helps to propel the notion that teamwork is important and teamwork is going to affect what matters, which is patient outcomes. And so I think that we have to look at that side of the coin as well. It's not just perfecting the design and implementation of team training, but everything that goes around. It's going to be a whole system that matters. Interprofessional teamwork should be trained early. We saw that student trainees had the greatest enhancements in learning. And so we really need to leverage this finding and start interprofessional education and team training in specific as early as possible before those negative biases can develop and fester and translate to poor teamwork on the job. And finally, we need to leverage simulation. We did find that it enhanced team training, but we need to be sure that we're preceding it and building upon competencies and pedagogical principles of the teamwork knowledge, skills, and attitudes that matter. So we need to use it in combination with other strategies to see the most optimal and maximal effects. So some limitations of our research that hopefully will spark some interest and spark some discussion into what the future of IPE and team training evaluation looks like. So as I mentioned, the majority of studies looked at post-licensure samples. While this is what the literature looks like, team training is mostly implemented in practicing clinicians. We need to start evaluating IPE early on in medical education. And team experiences early on will carry over to on-the-job attitudes. Next, we found very few studies that measured outcomes over time. So they might have measured patient outcomes, but 6 months out. We need more studies that take a longitudinal approach, that measure these same 5 outcomes over time so that we can understand the shelf life of team training, how often we need refresher courses, and what kind of sustainment tools need to be put in place to see and maintain the positive benefits of team training. And some sustainment tools that have been leveraged and used in the past include pocket guides that serve as reminders of the team skills that were trained, posters on the wall, checklists. There's many little tips and tricks that help to sustain team training outcomes. Future research should also evaluate interprofessional versus uniprofessional team training specifically. So we were able to do this meta-analytically, but we were comparing very different studies that implemented very different team training programs. So I believe that future research should, in addition to a control group, also look at team training in uniprofessional versus heterogeneous groups to see, by controlling for everything else, we can see the true impact of team training on each of those groups and kind of condense or distill down which features of the training need to be enhanced for interprofessional teams. We also found in our review of the literature that there was significant heterogeneity among studies in terms of the methods for evaluating training programs. Some of the speakers before me touched on this a little bit. Randomized control trials, pre-post, but some articles had to be excluded from our analysis simply because they only provided post-only data, so they didn't assess any baseline learning or knowledge of teamwork skills, any baseline behaviors, so we couldn't use those. So that just, begs future research to engage in robust and rigorous methods for evaluating team training programs, because otherwise we can't really discern anything from those efforts. Not all primary studies provided explicit information on the components of training. And again, this mimics one of the speakers before me. Many of the articles just say an adapted crew resource management training. And while we understand and it's written about what crew resource management is, we need to know what was adapted to be able to tell this works or this doesn't work. And so, again, future research should try and be explicit about the specific features of team training, what competencies were used, how long it was implemented for, how many times it was implemented, what kind of practice, what type of simulator. All these specific details are going to be helpful in propelling us forward. So lastly, there are very few patient outcomes reported. While we did have 3 studies that did, future research should try and make that link, and making that link is very difficult. You're going from team training to patient outcomes, and like we've heard before, there's a huge, complex process that happens in between. And so while that is true, we do need to try and get to those distal outcomes so we know that all the time, resources, and cost, money that we're devoting to team training is valuable, it's worth it, and that there's a return on investment. So to conclude, we did find that team training significantly improved each of the 5 outcomes in terms of the Kirkpatrick levels. So the cost of not embracing interprofessional teamwork and team training are significant. Research on interprofessional education should continue to uncover the most effective ways to develop, implement, and evaluate interprofessional education programs. And what I didn't write there is also to sustain team training outcomes. Because even if we show that it is valuable and great, we need to know for how long and what we need to do to maintain those great effects. So, thank you, everyone.